CASAT Podcast Network.
Hello and welcome to Season 3 of CASAT Conversations. I am your host, Heather Haslam. This season, we will explore the weighty topic of health equity. Within each conversation, we will discover insights from researchers, practitioners, and experts on this complex and important topic. We hope you enjoy today's conversation. Today, we are joined by Z. Lee, Assistant Professor at the University of Nevada, Reno School of Nursing, and Assistant Dean for Diversity, Equity, and Inclusion. Welcome, Z. We are so happy to have you here today.
Hi, Heather. How are you?
I'm well, thank you. So as we get started, I'd love for you to tell us a little bit about yourself and what inspires you to do the work that you do to promote health equity.
Okay. Hi, I'm Z, and I have been a nursing faculty at Orvis School of Nursing since 2015. Before that, actually, I've been working in nursing for quite a while. I work at Renown Regional Medical Center for 15 years, and my clinical background is trauma, neurosurgical intensive care, and so my entire career was in that kind of setting. And I don't know if you know the trauma center at Renown Health covers the entire Northern Nevada part of California. So there's a big service coverage area, and basically, whatever we see on TV comes to that environment. And really, I got into nursing by accident, and really just my friend wanted to take a class. I went to with her in one summer, and then that was it. And then that was a CNA class, the Certified Nursing Assistant course. And that's how I got to know nursing. And once I took that class, and something clicked in my mind, and I just love the feeling of taking care of people, and also just feeling so rewarded afterwards. And so I decided to get into nursing, and then pursue a nursing career. So for me, really, I see myself my career as a journey in terms of professional growth. And in my career, I continue to see the changes in our community in terms of healthcare access, and also the issues related to health equity. And especially in my clinical setting, and we deal with all kinds of people coming in for different reasons, and often we see now everybody has the same access to healthcare or resources, and because of that, the healthcare outcome is largely affected. Even though healthcare professionals, we're trying our best to provide those services, all that. And there are a lot of reasons that tie into it too, because in our community, there's some resources issues, there's some structure issues, and because of that, it become a daily challenge, really, working in the healthcare and to address those health equity problems. And I would say that was the initial reason. That's what inspired me to really look into, not just at the beginning. At the beginning of my career, I remember, I thought nursing was just about taking care of people and then help them recover and then send them home, and that was it, right? And then that was my initial, really, as a student. I was like, oh, this is. But as I learn things in school, and then really realize it's not just we can take care of the patients, and everything else will be fine. It's not that. It's a lot of things actually happen even before they get to the hospitals. So so that's what initially inspired me. And as I go through my career, I began to continue to work on things that really target how to promote health equity in our community.
I love listening to kind of your purpose and your why for how you got into nursing and what fuels your passion. And it sounds like your heart is in supporting people, and your journey through nursing has really highlighted the complexities of what that looks like, right? As students, we go in thinking it's one thing, and then you
Yeah.
get in, it's a whole lot more than we ever anticipated.
Absolutely, absolutely. I always consider myself very lucky, because I feel like I just happened to get into this career. Before I went to take the CNA class, I had no idea what nursing was all about. I had no idea. I simply just went to the class because of my friend, and really, and all these years later, and I look back, I always tell my students this as that, because my students always ask me these questions, or we talk about why you got into nursing,
Mm-hmm.
and then my answer to them is, I said I really didn't look for it. I got into it, however, and I just fell in love with it. And then to me, for that, I consider myself
Mm-hmm.
very lucky to have a career like that.
Well, it sounds like one, you stumbled into it, but then when you stumbled
Mhm.
into it, all of a sudden this light bulb went off, and I was like, oh,
Yep.
this is what I want
Yeah.
to do.
Yeah.
And
Yeah.
yeah, that's wonderful.
Yeah.
So I'd love for you to share with us some of the research that you've
Mhm.
done within your career to understand the human dynamics in our healthcare
Mhm.
system.
Okay. Yeah, that's really my passion, and also a very broad topic. Currently, I'm a PhD candidate at University of Arizona, and I'm in the program called Data and System Science, and that's one of the focus areas of the program. And what that area is all about is, we use data analysis to really looking into the issues in the healthcare system. And I love numbers, and that's just me. I'm that kind of person who who enjoy numbers, who enjoy data, because I feel like data is just. I know some people don't. I just feel like the data is fascinating because it gave us the most accurate, you know, the results, and also can help us predict the trend of things. And so I'm definitely more toward to quantitative research. I love qualitative though, just because I feel like it gave us a lot of rich background. But in the meantime, I definitely are more drawn to quantitative, just because I feel like the numbers can tell us so many things. Um, so human dynamics in healthcare system, and this tie back to previous question, like my entire career. I got into nursing leadership very early on in my nursing career. I became supervisor of clinical nursing, I think right before I hit 2 years, um, as a nurse. And then so my nursing career journey is not just the bedside. I'm very clinical driven, and but also is that nursing leadership journey. And so I have been involved in a lot of um, projects in terms of implementing best evidence-based practice, policy making, and develop new protocols. And also I experienced a lot of development of healthcare technology. Um, you know, and then as I continue to mature in this nursing leadership journey, and then I realized it doesn't matter what technologies we have, um, what protocols we have. And at the end of the day, it's the end users that matter.
Mm-hmm.
It's the people. It's the people that matter, because people are the users who actually implement whatever we develop. So it's not necessarily how advanced that technology is. So that was like an aha moment at some point in my career. I realized, especially, when I work as a manager at Renown, I became the manager of the trauma unit. I never left that unit, so that was my home basically. I stayed there for like about 15 years, from CNA all the way to a manager. So working with the team, and that's something I learned from the team. I realized that actually people are the most important, not necessarily the technology. So because of that, I start to pay more and more attention to the human dynamics, meaning like the dynamics of the team, of the users, of our daily operations in the system, and then how that affects our care quality and outcome. So when I remember when I applied for the PhD program, and I already have a very, very clear vision in terms of what I want to do with my PhD study. And that's one of the reasons why I chose the U of A, the nursing program over there, because not only they have the data system science track, and for me that was like, oh my gosh, this is like what I have been looking for. But also is that the the faculty there have a lot of experience in terms of what my research interest, healthcare leadership, nursing dynamics. And so through my research, I reviewed a lot of leadership theories and all those things. And two of the leadership theories that really stand out for me and resonate what I believe. The first one is transformational leadership theory, and the other is quantum leadership. Um, and those two theories, in my research, I combine them. So transformational leadership is primarily focusing on people centered, right? And it's very different from the traditional uh, authoritative type of leadership. It's not like you're just barking orders to people and make everybody work for you. Transformational leader is the person who actually help the team members to grow, to be their best, right? To take their input, and then engage everybody in the team to drive the excellence, right? So that's
Mm-hmm.
transformational leadership. Quantum leadership is recognize the multidimensional structures in the organization. And to me, that's crucial. So, in my mind, the theoretic framework in terms of um, leadership is really recognize that multidimensional structure and then the communication channels associated with that, and then also the transformational leadership, how you engage people across multi levels within the organization. And then so yeah, so really that's to me, that's the theoretical framework from nursing leadership perspective to drive how to understand people communicate in the healthcare system, how to work together to generate meaningful outcomes. So that's the my current research area, and particularly currently, with my PhD study, I'm really looking into the turnover intentions among acute care nurse leaders. And the reason why I want to study more of that now, number one is it hasn't really been studied extensively, this topic. So there's definitely a need for that. There's a huge gap in the literature that you know that's waiting for us to find out more. And people hear about nursing shortage quite often.
Mm-hmm.
We need nurses, right? And so when we talk about nursing shortage, it's all about the frontline nurses. But very, very few times that, not very often we hear people talk about nursing leader turnover, nursing leader shortage. And I'm not talking just about the practice setting. I'm also talking about, in academia or both, really. And so that's what triggered my research interest, because I want to see, because my current focus area is really the factors, the contributing factors associated with turnover in tension among nurse leaders. And those are the things that, that haven't been really studied that much. There are some pieces here and there. However, knowing those factors could lead to the possibilities in the future to develop interventional research. What that means is to develop strategies to really look into how to improve nurse leader retention, because research has already shown nurse leader, the quality of nursing leadership, and also the competency of nursing leadership are directly related to frontline nurse turnover. Which kind of makes sense if you think about it, is that if you have a boss that's really, supportive and then, very good, right? Of course, the team members wants to stay. But if you have a boss that just, doesn't support people, doesn't know, doesn't have the competency, of course, people will leave, right? So yeah, so those are the things that really drive me start to look into, this type of research. And then years ago, and a lot of people who know me know I was very clinical driven. I love bedside skills. I love clinical skills. However, and at one point, when I get to graduate studies, and I realized really people matters. And so I switched my gear from just really looking into clinical skills to really looking into people. So I dedicated my master's study, to diversity and equity inclusion. My master's thesis was about cultural competence between nursing students and practicing nurses. So look into the differences between those two settings and the two type of populations. And then now PhD study, I'm looking into nurse leaders. So, I anticipate my career really continue to focus on research in this arena and really looking into human dynamics. And my ultimate goal really is interventional research, which means that, once we identify those factors, then the research will be focusing on how to develop the strategies and how to test them and modify them, things like that.
I'm curious, how do you think that the turnover, whether for nurses or nurse leaders, how do you think that impacts patient outcomes?
Oh, that has been well documented in the literature. So, because here's the thing, just like any other industry, it's not just nursing. If you don't have enough labor, then the quality of your product will be compromised. So in nursing field, the same thing is that if we don't have enough nurses, and we will have to be stretched super thin to cover the patient, right? Because patient will always come. It doesn't matter, and that's just a reality. It doesn't matter what our society is. People get sick, unfortunately, and people get into accidents. People need surgeries. So they will always come to the hospital. And as nurses and in the hospital, and our COVID pandemic is a perfect example, right? So in order to cover the patient load, we have to just, if we don't have enough people, then everybody has to work overtime, everybody has to work overload to cover that, right? And the issue with that, not only just the quality of patient care, because guess what? We all get into that mode of doing the minimum, right? Even though we want to do more, but it's impossible because we don't have enough people, we don't have enough time. So the first thing that get directly impacted is the quality of patient care. Okay, the quality of patient care and the outcome, right? You have increased the mortality rate, right? Increase the hospital readmissions, increase the length of stays in the hospital. And those are patient care related, outcomes. And the other part, there's all the other things that will be affected, greatly. For example, is the burnout, right? Because people work overtime. I mean, I experienced that myself when I work at bedside. You're supposed to work, 3-day, 12-hour shift a week, and that's you're considered full time. But in reality, I signed up a lot of overtime back then, just because you don't want a team to run short, and so you go in there and cover. And many nurses do that, especially during the pandemic, you know. But when you do that, how much do you have the time to recover, right? So that continue to go. So that link to, your physical health, mental health, and all those things, and eventually that leads to burnout, right? And so there's so many factors that ties into it. And then if the team end up having a nurse leader that doesn't have the competency and doesn't know how to build the team together, that's even worse, right? Because the staff don't feel being supported, right? And then the other part that's very detrimental to nurses' health, especially mental health, is the moral distress and moral injury. So what that means is when nurses when they were in school, they were taught so many things, like what would be the right thing to do, right? What would be the right things to do for patients. So everybody has that knowledge after they graduate from nursing school, and then they got into the practice setting, because we don't have enough people, so everybody gets into the doing the minimum mode, right? So pretty soon, think about, you have this ideal situation, in your head. It's like, this is what I'm supposed to be doing for my patient. But in reality, this is actually what happened to my patient. Day after day, then that will develop what we call the moral distress. Is that you're not really doing what you want to do, right? And then the worst situation will be moral injuries, and that tied into nursing ethics, a lot of ethical dilemma, those are the things. And all these contribute together, and then contribute more turnover. So to me, this is a vicious cycle.
Mm-hmm. And many layers.
Yeah.
Lots of complexity.
Many layers and many factors. However, everything is connected. Mm-hmm. And this cycle continue to roll even today. Mm-hmm. Even today. So that's the reason why, that's another reason why I'm doing the research I'm doing, just because I felt like there has to be something. We gotta look into the current situation from a different angle. Mm-hmm. From look at things. We can't just continue to produce new nurses and then continue to burn them out. Mm-hmm. And then, research has already shown, the nurses who leave the nursing profession at the highest rate is between the graduation and then 2 years after being a nurse. Mm-hmm. That's the highest rate. So, so that tells you a lot. And the nursing shortage is not a new phenomenon. It's like, it has been like that since I was a bedside nurse, or even before that. So, so that's the situation we're in right now.
It makes a lot of sense to me. I have taught for the School of Public Health, and get to teach students who are undergrads who are trying to get into the nursing program. And even the way that we talk about getting into different healthcare programs, there's already a tremendous amount of pressure and anxiety even before being admitted. And then I think about the training, and I think there is a culture shift in how we're training healthcare provider students. We'll just make it broad. But it is like this grueling process, right? It's like put your life on hold for X number of years, and like you just have to barrel through. And then they get out. And so I'm always curious, even like, what is the burnout level before they even start practicing in a way? So then it's like that 2 years, right, is actually more like 6 years because of how long it's taken to get to where they are.
Yes. And then that's, and that goes back to why I'm so passionate about human dynamics in healthcare. The nursing education in general, because we have a very short program. Because if you think about it, the nursing academia is facing the pressure from the industry, and let's do a math here. Our traditional program at Orvis School of Nursing, we admit twice a year. Each cohort 64 students. And the whole program is only 16 months. So we're talking about 4 semesters, including summer, and they're done. And they take NCLEX and they become nurses. And that's how fast we produce nurses. But why we still have nursing shortage? I mean, we're only one of the schools in the area. We still have TMCC, WNC, and Carrington, other nursing schools, And then I remember when I was a nurse manager, every semester we do this mass interview, and then to interview the graduates, and that happens all the time. So something is now adding up here, So that's why I was doing, I want to do the research in terms of retention, in terms of this all falls under the big human dynamics umbrella. But to your point, Heather, is that a lot of times I feel like, why are we the way we are and how do we get here, right? And then that makes you wonder, a lot of things actually start in nursing academia. Started when we were in nursing school, right? So, and then I'm, right now in my current teaching role at Orvis, I have the luxury, the opportunity to teach both graduate level and undergraduate level. And for my undergraduate level, I'm actually, the clinical coordinator for the level 1 clinical course. So those 64 students there, that's the brand new nursing students, their first semester, And then I think faculty, we all have our own teaching philosophy and teaching practice, And for me, my teaching philosophy is, really focused on compassion-based teaching, and I don't believe fear-based teaching. I think it happens in the nursing industry a lot. You guys probably hear the saying that nurses either young or something like that in the social media, things like that. And that happens. That happens both in practice setting and the academic setting. I don't know why. But we really try to create a culture that we're educating the future nurses. We don't want them to, by the end of the 16 months, and they are already burned out and jaded, and then lost that compassion, and then go into the industry. Does it happen nationwide? Absolutely. I mean, I can't say we do it we prevent that 100%, but we're trying our best to minimize that as much as possible, because it's important. It's important. So it's all about how to support students so their learning outcomes are guaranteed. Um, to me, and that to me, there's a really a fine line between compassion and accountability.
Mm-hmm.
So the students need to be held accountable. They need to be held accountable with their professionalism, their learning, you know. But in the meantime, the faculty also needs to be compassionate. And I see myself as the main part of my role is to inspire and role model the behavior. And that you tell students, this is, what the industry needs, what the industry wants, and those are things, and guide them through the process. A lot of times, the students, especially, we're as educators, we're facing the challenge that brought up with the newer generation, right?
Mm-hmm.
And so yeah, so the way how they see the world, the way how they interpret the world is very different. It's very different compared. I mean, my students, a lot of them, they're like 19 years old, 18 years old, or just turned 20, 21 while they're in nursing school, right? They have a different perspective. And as educators, we learn a lot from them.
Mm-hmm.
And, we do. And I really feel like, as, we consider ourselves as the change agents because we're the educators, right? But in the meantime, we had to be able to adapt to the change fast as well, and then customize and improve our teaching strategies, right? So yeah, so
Mm-hmm.
back to the topic we talk about. All of these are connected, really.
Right.
When it comes to nursing shortage and turnover, retention, those things.
So I know that you worked in trauma care for quite a
Mhm.
while, and I'm curious, what did you see with regards to underserved populations? Because I think that's
Ah,
part of this
yeah,
layering and this dynamic.
yes, yes, and I have been living in Reno since 1999, and really this is my home, and really looking to, while I was working in the hospital, and even right now teaching, that I think our community is unique, has its unique needs in terms of underrepresented populations, and then in the healthcare setting, that happens every day. That happens every day. So really, I felt like there's a lot of, I mean, the community. I know the community. Every entity has been trying, but still there's a lot more work to do in terms of underrepresented population. And in my clinical area, I mean, when people come to our unit, I mean, it's bad, because we work in the intensive care unit. So so when they get to our unit, they were all in bad shape, and our job is to treat, really, no matter what, right? Because we don't say no to patient. But to me, there's always that difference. Once we stabilize the patient, whatever reason they came in, and there will be different things happening depending on who that person is and where they come from. We had a lot of homeless patients. They got into accident. Um, some of them got you know assaulted, um, unfortunately, and then came. And those patients usually don't have families. They have no support system whatsoever. They have no pay source, nothing, right? We work a lot with social workers, case managers, try to set up things for them. Um, the other part is associated with, some of them also have mental health issues, addiction issues, you know And the other patients who are not homeless also came in with those issues, depending, and yes, in theory, we learn in school that we're supposed to treat, we're not supposed to be judgmental or infuse our personal beliefs into the care. Those are things we talk a lot in school or in theory, but it's not the same. It's not the same in the practice setting. And often I feel the underrepresented people, the populations, become a victim of that. Become a victim of healthcare stigma, and the stigma that stigma exists among healthcare providers, unfortunately. And so because of that, the care quality and the care outcome are affected because of that. So in my clinical background, I've seen a lot of patients came to the unit with addiction issues. Many of them came to ICU because they were withdrawing. They're withdrawing with whatever they were addicted to, and it was difficult to watch. It was difficult to watch. But what's more difficult to witness is the practice from healthcare providers that was affected by stigma. Because often some patients will be labeled as drug seeking or drug users or whatever, and because of that, there was a lot of issues associated with that when it comes to care delivery. And then sometimes the healthcare providers don't provide the optimum care as needed, simply is because that their personal beliefs. And that exists everywhere. And I honestly, I think the pandemic really actually exacerbate the situation a lot, because a lot of things became political. When it comes to mask, wearing a mask, to vaccination, all those things. And and because of that, you see this on social media, you see this, when people post their opinions and all that, and then that infused into our care delivery. And which is quite, is a quite a significant issue in our healthcare system. And then I look back in my career, either in the practice setting or in the academic setting, it still exists. It still exists. And I feel like as educators, we have the responsibility. We have a lot of work to do in terms of really educate future nurses, and then really look into how we can address the stigma, and also be self-aware, of the situation, and sometimes it is difficult to really, in my unit back then, we took care of a lot of patients who were criminals, came to the hospital. I mean, just things like, they did something wrong, or they were actually from the prisons, um, all those things. Or um, we have people who absolutely have no access to care, came in with tons of health issues. Um, those are the things, right? But in the meantime, they were addicted to certain drugs, or people who are not complying with some sort of therapy. For example, diabetes. We have, and I often hear people say, "Oh, that's a frequent flyer." They were labeled as a frequent flyer because they always come here. They always come here because they were not compliant, you know? And I hear people say, "Oh, how come they just can't take their insulin or whatever," you know? But the thing is that I feel like every person has a story behind themselves, you know? And then when they come to the hospital at that moment, it's really now up to us to decide that, to judge on that, you know? But it happens. It happens. And then what I see in my career is the when it comes to underrepresented populations in our community, and very often, very often their care is affected because of their socioeconomic status in society. And then and that's a significant problem. That's a significant problem. And then I felt like, one of the solutions we can continue to work on is educate, not just to the students, also to our current healthcare providers, is that how we can be self-aware,
Hmm.
and then really focus on the care we deliver, not necessarily deliver the care based on whatever we believe. So
Well, and that goes back to what you originally shared about this shift that you had in perspective when looking at clinical skills. And of course, clinical skills are important, but
yeah,
these human dynamics of caring for other human beings and working with other human beings, and that judgment and stigma and how it plays a role in patient outcomes is huge.
and that's the thing. I have worked with so many amazing clinicians, physicians, nurses, respiratory therapists, you name it. I also encounter people, I work with people who had amazing clinical skills, but always do the minimum, you know, which
Mm-hmm.
is, I mean, that's their personal choice when it comes to practice. However, that shows the people are the determining factor, the ultimate factor that will impact care quality and care outcome.
Yeah, that makes sense. And I think back to what we were talking about with burnout and like this resourcing that people have, right? Like that
Yeah,
minimum level may just be the amount that they have to give that day,
yeah,
because of being so under resourced and so depleted
yeah, yeah,
in some ways, right? It's like I have nothing left to give.
yeah, yeah, really. And then that's the thing that if, and and different specialty have a different ratio, for example, right? Because of acuity level.
Hmm.
And when you get to the point that you have to take on more than that what you should take, based on acuity, the only thing you have left is do the minimum,
Hmm.
you know? And then that's a really, really tough situation for the nurses who actually want to do more, who actually know what they're supposed to be doing for the patient. But like what you said, they simply have nothing to left to give.
Hmm.
So
I'm curious, as we talk about stigma and judgment, you talked about self awareness being one critical aspect for understanding identifying when a person
yeah.
is judging or stigmatizing another. Are there any other strategies that you've seen to help
Mhm.
alleviate some of that?
Well, I think the number, for me, from teaching perspective, I always tell students this question always pop up in the when I teach undergrad students, and is that they felt uncomfortable a lot of students feel uncomfortable in a clinical setting. On top of that, they're now familiar with the clinical setting because it's their first time, in nursing school in the first semester. On top of that, there's also another layer of issue is that they're now comfortable carrying uh, the type of patients they're now really familiar with. For example, they could end up being assigned to a patient with a chronic drug user, right? Or they um, we always have the conversation about caring for um, patients who are, from the LGBTQIA plus community, and you know, and things like, because right now these days healthcare, when they do admission profiles, they're asking, the specific gender questions or preferred identity questions, and sometimes some students don't feel comfortable. They don't know what to say, and they will ask faculty, "How do I even approach?" You know, and I told them, I always tell my students, I say the best strategy, it doesn't matter what patient, is to talk to them, ask them, and communicate with them, get to know them, right? Get to know them. And then I say, if you go in there, go into a room doing a patient initial admission interview, right? I said, you got to personalize that experience. You can't, I said, I don't recommend people holding a clipboard and going in there. Hi, I'm Z. I'm your nurse today. I have some questions to ask you. Right? I mean, think about it. Think about it, I mean, that kind of approach, of course, people's like, okay, why do I want to tell you everything about me, So that's one strategy I always tell my students is that when you communicate with patients, treat them like a person first.
Mm-hmm.
Then don't think about the moment you go into a room, you're actually having a task. Yes, you do have a task from patient care perspective. However, that communication, and that back to the whole topic about human dynamics, right? That communication, you gotta personalize that. So that's my, probably the biggest strategy. And I think in our healthcare education, either in nursing or physician or nurse practitioner, you name it, right? There's a room to really help us develop communication strategy.
Mm-hmm.
When we communicate with patients, it make huge difference. It make huge difference. And especially when it comes to those underrepresented population, they are fully aware of the stigma in healthcare, right? And back to the topic like LGBTQIA plus community, the research has already shown a lot of them, they're very reluctant to seek healthcare because of the stigma in our society,
Mm-hmm.
right? So as a healthcare providers, we have the responsibility to really think about how we can actually develop the care strategies to make them feel they're getting the care quality they deserve, right? So yeah. So, and a lot of times, in our country, a lot of things become political, really. And also everybody has our own personal background. So whatever we believe gets in the way, you know. But sometimes, a lot of times it's simply because we just don't know. We don't have that knowledge, right? So
Mm-hmm.
yeah, some of my students, were assigned to a transgender patient, and they were very nervous. They don't know how to approach. How do I even say? I said, why don't you ask the patient how she wants to be addressed? You
Mm-hmm.
know, and then they will tell you, right? So yeah, so those are the things, and and I feel like as a healthcare providers, we should have that clear mind and the self awareness. It doesn't matter what the political climate is going whatever way, right? Our care shouldn't be affected, right?
Mm-hmm.
And some states can be very liberal and some states can be super conservative. But none of those things should be the reason why that we can, change our care quality or outcome. I don't believe that. You know, I don't believe that. I mean, this morning I just saw the news that Florida passed the "Don't Say Gay" bill. Did you see the news this morning?
Mm-mm.
Yeah. Yeah, they passed the bill, to ban every discussion in school, in the elementary school, talk about sexual orientation or things like that. So things can become very political.
Mm-hmm.
But because of that, um, the underrepresented population, the LGBTQIA plus, um, community in that state, they are facing more stigma,
Mm-hmm.
from society or things like that, and that turns into another cycle of I don't want to seek healthcare or treatment. I can tough it up as much as I can. And those populations, by the time they get to the hospital, a lot of times they're already delayed. A lot of things are already delayed, right? So that links to our health equity issue. Those are the things and I think for our society as healthcare providers, we have the responsibility to, I don't know, neutralize is the right word for that, but really we're the one should be the one who are balancing everything that exists in our society to address health equity issues.
Well, and what I hear is judgment, right? Like
Yeah.
human beings don't want to be
Mhm.
judged. And so
Yeah.
if I feel like I'm going to be judged, I'm not going to go there, or I'm not going to share
Yeah.
everything, right? All of my
Yeah.
health history,
Mhm.
as well as psychological safety, right? Like if I
Exactly.
don't feel safe to have a conversation with you, then I'm not going to share anything. And then that then leads to poor health outcomes, and poor clinical skills just based on judgment, right? So
Yeah.
this
And then,
it's that cycle.
yeah, and also the potential for psychological trauma
Mm-hmm.
in the process of seeking care.
Mm-hmm.
And because a lot of times because the stigma existing among healthcare providers. Oh, I've seen it. I've seen it in the hospital, working in the hospital. I've seen the nurses and do very, very minimum simply because what that person laying in bed had in the past or what that patient did, you
Mm-hmm.
know? And sometimes it's hard. It's hard. And then, and it's hard for healthcare professionals to balance that, you know? I mean, in my unit, we back then we took care of patients who were the one who shot and killed the police officer, right?
Mm-hmm.
And how you can balance that, knowing, right? Knowing this person did something really bad, and in the meantime, you still have to go in there provide that care. So
Mm-hmm.
sometimes it's hard.
Well,
It's
and
hard for
that's the human dynamic part, right? Like,
exactly, and how you communicate, right?
mm-hmm.
How you really carry on that care.
And
So
how you process the experience in and of itself. And then again, going back to the self-awareness piece, you have to be self-aware enough to know what you're actually doing.
yeah, definitely.
Because
And that
sometimes
part,
it's not even, sometimes I think it can be unconscious as well.
exactly. And that part, and to me, I think that part is probably the most challenging part. So I think, back to the topic about strategies, really the other strategies among at the healthcare provider level, and then that conversation needs to be ongoing. That continuing education needs to be ongoing. So, and that can be done with so many different formats, right? That could be a routine small group, kind of like a group, like conversations. It could be um, within the organization, some sort of like a workshops routinely, and provide that safe space for people to share their experiences. You know, mental health, mental trauma among healthcare providers is a huge topic. It's a
Mm-hmm.
huge topic these days. You know, so but think about it. These days, how often does healthcare providers are provided a safe space to share what they feel, how they feel, and their experience? Not really. You know, I mean, it's getting better, really, but in
Mm-hmm.
the meantime, is that you know, It's like we're so used to just go every day because we're so overwhelmed with the workload. We just keep going, and we barely have the time to really sleep or eat or whatever. And not even mentioning we have the time to actually slow down and reflect. And then that's a huge issue, right?
Mm-hmm.
So yeah, so that's what eventually leads to compassion fatigue.
Yep. And that takes us back to how we started this conversation on like the impact of the nursing shortage and actually having enough people to do the job so that you can slow down and have that time to process these human emotions that happen when you're treating patients in these very complex world we live in.
Yeah. Absolutely.
Well, I'm aware of our time, Z. As we wrap up, is there anything else that you feel is important for our listeners to know?
Oh, I didn't realize the time goes by so fast. Well, I think, one thing I would like to really circle back is that when it comes to behavioral health, and I do believe behavioral health exists in every single layer of healthcare. And then, for example, myself, that I'm not, my clinical background is trauma, surgical, neuro, intensive care, but I feel like a behavioral health exists in every single day practice in that place, right? And our mental health, our mental being. I work with a lot of behavioral health specialists for our patients, and I think, and so it's right now in nursing school. I'm a teacher, and behavioral health is so important because the mental health needs and also the students' needs in general, and how we can work with behavioral health professionals to make sure they're well supported so they can have the best learning outcome, right? So I do feel like behavioral health professionals really, I almost see them as the catalyst in the healthcare system, because they can be so powerful. They can be so powerful in every single specialty, because the way how they can connect different fragments in healthcare and to make things work well together. So I felt like what's the most important for the future behavioral health professionals is that to develop that broad mind and realize that your practice is not only focused on treating the patients with behavioral health issues. The behavioral health professionals actually have the capability to really connect the fragments in healthcare, to work with other professionals from different disciplines to have the best patient outcome.
Yeah, and they really are the ones who deal with some of these human dynamics so well that we've been talking about today.
For sure.
So kind of that glue in a way.
Yeah. They build everybody together, and that way, because at the end of the day, we cannot work in silos in healthcare. And I think that's one of the fundamental issues in our community. Things fall through the crack, right? When people work in silos, and that's what it is.
Yeah.
So, yeah.
Well, thank you for doing the work that you do to really change the culture of how we train future nurses, as well as looking at how do we retain the nurses that we have and looking at these very important human dynamics. Really appreciate you sharing all that you've learned along your journey with us. And thanks again for your time.
Thank you so much for having me.
Thank you for listening to CASAT Conversations, your resource for exploring behavioral health topics. We hope you found today's conversation timely and meaningful. Please share this podcast with your friends and colleagues. If you want to learn more, visit us at our blog at CASATOnDemand.org.
CASAT Podcast Network. This podcast has been brought to you by the CASAT Podcast Network, located within the Center for the Application of Substance Abuse Technologies at the University of Nevada, Reno. For more podcasts, information, and resources, visit CASAT.org.